Great. Hi, everyone. I'm just going to give it another 5 minutes just to let everyone join in, and then we'll start at 8:05. Okay, so that's 8:05. So welcome everyone back to another session in the Mind the Bleep Urology series. So today we're going to be talking about clot retention and how to manage it. And before I go ahead and introduce today's speaker, I'm just going to give out a quick message from one of our sponsors. If you don't mind, just jumping to the next slide, please. So essentially, we've partnered with CPD.me, and they're allowing us or providing us with hundreds of CPD accredited webinars. They have a really cool application which you can find on both Android and iOS. And essentially they have like a nice drag and drop interface that you can use on your phone to allow you to record all your teaching sessions. And it's designed for anyone who is registered with either the GMC, the NMC, or any other healthcare professional, really. So they've given Mind the Bleep users a 50% discount. If you use the QR code provided on this slide, it'll give you basically an £8 per year membership, which if you're interested in, go ahead and use now. So going back to our session, today's speaker is going to be Nikita Bhatt, who's an ST6 in urology, and she currently works in Cambridge University Hospitals. So without further ado, I'm going to go ahead and hand over to you.
Thanks for having me. So I'm going to talk about clot retention and its management. So the objectives of today's session are going to be, first of all, what is clot retention? What causes it? How would you expect your patients to present? How would you manage it? And then we're going to go through a case at the end, try and make it interactive. So what is clot retention? It's a sequelae to bleeding in the urological tract, and it's an inability to urinate owing to the volume of blood clot in the bladder. And if this happens, it's a true emergency because the patient can't void. So what really causes it? So at the basis of it is that any cause of visible hematuria can potentially lead to clot retention. So when you develop a large amount of blood in the bladder that exceeds the ability of urinary urokinase to prevent clot formation, it results into clot retention. So urokinase is an enzyme that promotes clot lysis by converting plasminogen into plasmin. And then when these clots accumulate in the bladder, it results into retention of urine, and the clots then physically block the urethra or the bladder neck. And that's what clot retention is. So as I said, any cause of visible hematuria really can result into clot retention. Common causes include things like malignancy, BPH, trauma. Commonly on urological wards, you'd see this post-operatively after bladder outflow obstruction surgery or bladder cancer operations. Like a TURBT. So presentation, the patient will present with retention, so a suprapubic distension, severe discomfort in the lower abdomen. If they're already catheterized, you'll start seeing bypassing of fluid around the catheter. They might be dribbling some blood-stained urine, or they might actually be passing urine with a few clots, and it's increasingly painful to pass urine. So if you see a patient like this in A&E, so obviously you go through your basic management, so your ABCD, make sure they're stable first, and send off bloods. If they're unstable, you can do a ABG at that point. Start fluids if they're hypotensive, etc. But for managing the clot retention itself, you've got two goals. You want to relieve the outflow blockage, and you want to prevent new clot formation. And the key to doing this is a three-way catheter. I'm not sure how many of you are familiar with this, but I'm just going to go through it anyway. So a three-way catheter has an extra access port, which is called the irrigation port. So normal catheter just has an outflow port and a catheter balloon. The third port in this allows you to actually get fluid into the bladder, wash the bladder out, and then get clots out through the outflow port. So immediate management, once the patient has been stabilized appropriately, is to insert a large urethral catheter. Very commonly, we would end up using a 22 French catheter. I haven't seen anything larger than that being used, and it's a three-way. You start irrigating with normal saline. So the first thing you want to try and do is aim to remove all the clots in the bladder and establish spontaneous drainage. And the way to do this is with what is called a catheter tip syringe, which looks like this. It's usually 60 mils and has a tip that's quite different that goes into the catheter, and you're able to literally suck all the clots out. And once you've established some drainage from the bladder, you can start them on irrigation. I'm going to go through this video because I think it's really important to know how to do an effective bladder washout with a syringe.
This is Dr. Margolis. I'm going to try to explain how to irrigate a three-way catheter using a piston syringe. As you can see, the syringe has a hole at the end.
So we call this the catheter syringe in the UK.
Depending whether you're doing it two-handed or one-handed. We're using a three-way catheter, meaning it has a opening at the end that you can flush in and out of. This is generally the end that gets hooked to the leg bag or a drainage bag. The other part of the three-way is the continuous irrigation, which you see hooked up on the right. It has some blood in it, which is not unusual when the irrigation's not running, as it is in this patient. Eventually, when the clots are all cleared out, we can start that running, but it's never a good idea to run it until all the clots are clear. If you do, the patient is gonna have a risk of perforation of the bladder if you run the irrigation when there's no way for the fluid to get out. Generally, we start with 2 syringes just to be sure that we're not sucking against the bladder wall when we do pull back. The patient probably has several hundred milliliters when they come in with retention and you put the catheter in. So occasionally we will let it passively drain between installations of fresh syringes of sterile water. We do not use saline as it does not lyse the cells as well as sterile water does. And these clots are generally inches in diameter and need to be shredded in order to get out the rather narrow tip of the catheter. This is a plain 22 French latex catheter. It's not the one I typically use, but didn't have a choice here. Normally we use a Cuvelaire catheter by Ruche, which is a clear plastic one with a rather large mouth. We always make sure.
So essentially, I think you get the picture. You want to try and instill the sterile water. So for the washout, we usually use large bottles of sterile water. And then when you're hooking up irrigation, it's usually saline. So you need your entire kit ready before you go to the patient's bedside. You want to take any sort of bowls or sterile vessels you find in the ward, fill them up with the sterile water, and then start instilling the bladder with the water first. And then once you've got a little bit of water inside, about 2 syringefuls is fine. Then you start sort of sucking the clots out. And the reason is you don't want to catch the bladder wall if it's empty while trying to flush the clots out. And then you continue to do this a few times until you start seeing, as you saw in the end of the video, sort of a light pink, or what we call as a rosé colored urine coming out, which means you've removed majority of the clots, and that's when you can hook up irrigation. So this is a really important skill. A lot of the times you would say nurses are able to do this on the ward, which is excellent, but not everyone does it this way. And I think this is the most effective way of doing it. Some people tend to wash out with from the irrigation port and then just let the clots passively drain out from the catheter port. And that's usually not as effective as doing it this way. So you want to make sure the irrigation port is actually either clamped off, or you've got, as you can see here, they've just put the irrigation fluid and closed it off. So you can do either or. So that's the first step of management. But however, if you find a patient that you've done all the initial bits and their bleeding isn't settling, then the next step in their management would require rigid cystoscopy in an emergency setting in the operating room, and clot evacuation. And again, all you're doing is trying to get the clots out of the bladder. And the reason is when the clots stay in the bladder, they really irritate the bladder, they cause more bleeding, and then they block the catheter, they block the urethra. So you want to get rid of all the clots. And while you're doing this in theatre, you use an instrument called an ELIC, which usually just suctions out all the clots from the bladder. You can also use a bladder syringe at the end of a cystoscope to try and remove the clots. And then if you see any active sites of bleeding, you treat them at the same time.
This is Dr. Margolis.
Okay. Again, so once the urine is clear, you hook up irrigation. So if you've never seen this, this is how it's done. Usually you've got preferably 3-liter bags of irrigation solution. And the reason is because if it runs out, if it's a liter, it'll run out quite quickly and you'll be running around trying to get another bag and the patient will clot off again. So better to have 2 bags by the bedside, 3 liters each, connected to the irrigation board, and you want to achieve this sort of rosé light pink urine, and you make sure that it's infused via gravity. It's not on a pump or pressure, because if the bladder does get clotted off or the catheter gets blocked, and you're continuously infusing irrigation, there's a risk of perforating the bladder. So you don't want that. So you want to just make sure it's infusing through gravity rather than pressure. So once you've managed these patients, if the clot evacuation is treated, you want to then investigate them as a follow-up. Usually when their bladder is full of clots or there's dark hematuria, you're not going to be able to see much. And the vast majority of such patients, their urine will clear up, you'll send them home, and then you'll bring them back for hematuria investigations in your hematuria clinic. There's usually a flexible cystoscopy and upper tract imaging, either a CT scan or ultrasound, depending on risk factors. So that's all for acute management of clot retention. And then we're going to move on to our case. So this is an 80-year-old man, quite commonly seen presenting like this, who went to the GP after noticing some blood in the urine and difficulty emptying his bladder. The GP was quite concerned, sent him to A&E and admitted, and he was then admitted to the hospital via A&E. The urine was positive for infection, but the urine was quite bloody, so it was hard to say what happened first. So we started on IV antibiotics and transfused 2 units since admission. I'm told that people like this to be quite interactive. So if you could try and type into the chat box what additional history would be pertinent in such a patient. So there's a patient presenting with hematuria and a likely infection. What else do you want to ask the patient?
Okay, so we're just going to give it 30 seconds. You guys feel free to type some additional history in the chat box, and I'll have a look and relay that to you. Okay, so I have any history of bladder cancer or BPH. Mm-hmm. Someone mentioned asking about the onset.
Yeah.
Okay, we'll give it some more time. Family history, blood coagulation problems.
Excellent, yeah. So whoever said family history, why is that important?
They're just typing out their response. So yeah, so to know if there's any risk factors, basically.
Yeah, so you're trying to rule out in your head what is potentially causing the hematuria and clot retention. So there are certain familial sort of medical diseases, for example, clotting problems that could happen. And then some urological diseases as well could be familial, and yeah, so relevant. Yeah, absolutely.
Great. And to know if there's underlying factors like cancer or bleeding tendencies.
Yeah, that's really important, because obviously if someone has got a history of cancer, bladder cancer, for example, and they're having TURBTs or regular cystoscopy checks and they've come with hematuria, then you sort of understand why they're presenting like that. So yeah, that's quite important.
Any history of diabetes, someone mentioned.
I mean, yes, because they've got an infection, diabetes, it's important to know if the sugars are under control, because that's sort of a holistic management of the infection. They won't get better if the sugars are through the roof. So yeah, absolutely.
And someone mentioned the last time they passed urine or dysuria.
Yeah, so infection, obviously, dysuria is a symptom, isn't it? So that's important. The last time they passed urine is important because that gives you somewhat of an idea how long they've been in retention. So if it was like 24 hours ago, you know that they haven't passed urine in a day, and that means they are more than likely going to be in retention for that much time. So they need an urgent catheter if they're not in pain and they don't tell you that straight away.
Great. And then we have someone mentioned any history of catheter usage or traumatic catheter insertions recently.
Yeah, so anything that can potentially damage the urethra or the bladder, catheters can cause a lot of catheter reaction, and that can then cause bleeding. So yeah, and as I was mentioning, these patients who have indwelling catheters will present with sort of dark urine and lots of bypassing, and then you are thinking that there could be bleeding inside the bladder, which has caused a clot to get stuck in the eye of the catheter, and just you need to change that 2-way to a 3-way catheter at that point. So yeah, that's important.
Okay. And Dean has mentioned fevers. Claire mentioned anticoagulants as well.
Yeah, so absolutely. I think you have all covered everything that I've written here. So I'm just going to now go through it. So yeah, fevers or chills are really important because you want to see if it's a UTI versus urosepsis. Have they had any flank pain, abdominal pain, any past medical history? You've said all of this. So the patient the patient is known to have hypertension, he's obese, and he has actually got diet control diabetes. Past surgical history, he had a bladder stone removal about 5 years ago, and he had what he describes as a bladder neck surgery. Can't remember what it was exactly, years and years ago. Medication wise, he's on an antihypertensive, so no, he doesn't have any coagulation or bleeding disorders that we discussed. He doesn't have a family history of stones or any malignancy that we've discussed. And apart from that social history, you want to know because of the risk of bladder cancer. So he's a non-smoker, and there are no occupational risks. So occupational risks, to be honest, in the sort of an acute situation, maybe not as important, but in a hematuria history, this is important because bladder cancer has certain occupational risk factors. So yeah, you go through this sort of a standard history, and then the next thing that you've done is examine the patient. So for examining these patients, you want to look for abdominal tenderness, distension, which he has, and then you're looking for costovertebral angle tenderness bilaterally. Why would you do that?
Right, so your question was, why do we ask about costovertebral angle tenderness?
Yeah, or like, why do you examine them? So the way to examine someone's costovertebral angles are sort of right at the back here, in the general area of your kidneys, and you kind of sort of press around that area, and you just basically elicit any tenderness. And there's some description of you can sort of punch that area as well, but usually just pressing that is enough. Why do you think it's important in such a patient?
So we got a couple of responses saying to see if there's pyelonephritis.
Yeah. Yeah, exactly. So if they have pyelonephritis, they'll be tender in that area. So if someone is presenting to you with a UTI and is unwell, or even otherwise, you always examine the costovertebral angles to make sure there's no tenderness to sort of rule out pyelonephritis. It may not be present in everyone though. So if it's not present, doesn't mean they don't have it. And then you're looking for the external genitalia. Make sure that they don't have severe phimosis, etc., before you're going in to catheterize them if you're not comfortable with that sort of a situation and you need help. So always examine the external genitalia. And in retention in general, even though it's really hard to have a full-blown retention with phimosis, but it's good to examine the external genitalia. Good. So based on this history, I'll go back to this. What is your differential diagnosis of this 80-year-old man presenting with hematuria to your A&E? He's lost enough blood to require blood transfusion, and this is his sort of background. What is your differential diagnosis?
Okay, I'm just going to give them some time. So we have a couple of differentials here from Dean. BPH, cancer, infection.
Yeah,
another BPH. Malignancy of the prostate or bladder. Okay, BPH.
So to all the very intelligent people saying BPH, why is the top differential? And there's a reason in the history, so that's very clever.
I'll give some time for people to answer that question, but we got a few more answers initially. So we've got prostatitis, stones, and now Maria's just replied about BPH saying his age.
Yeah, absolutely. Something else in the past history that strikes you as a clue?
Dean has replied with age and past medical history.
Yeah. So sort of, you mean the metabolic syndrome prototype? Yeah, that's a risk factor. Yeah, but there's something else. So I'll ask this a different way. Why do you get bladder stones?
So Maria's replied bladder stone removal.
Yeah. So can someone just tell us, how do you get a bladder stone? Is it the same reason why you get kidney stones?
Okay, Michelle said no. Could one of you guys elaborate?
Yeah, so bladder stones are usually not the same etiology as a renal stone or ureteric stone. They're in developed countries, in adults, they're usually caused by bladder outflow obstruction. So there's something that doesn't let the urine drain. There's concentrated urine sat in the bladder, and that forms debris. The debris then calcifies and forms a stone. So that's how you form a bladder stone. And previously, the thinking was, if someone has a bladder stone, you go and sort of treat their bladder outflow obstruction, which is in the vast majority of cases BPH. So you go and just do the BPH surgery at the same time. But now there's more and more evidence to say you don't necessarily need to do this. So sometimes they'd have had a stone removed, and if they're not experiencing any lower urinary tract symptoms and they're emptying reasonably well, you don't need to do the BPH surgery in the same sitting. So yeah, that is one of the clues in the history that he could have BPH, because he's previously 5 years ago had a bladder stone removal. So it probably was due to a large prostate. And then the other etiology for bladder stones is sort of in developing countries and sort of malnourished kids, but I don't think you need to know about that. So absolutely right, bang on with all your differentials. Don't forget trauma in elderly people who've come into A&E. They could have had a fall at home, and you just check their flanks for bruising and stuff, and sometimes they could have, just by falling on their sides, caused a renal trauma. So it's worth remembering that. Okay, any questions so far in the history or the differential?
Anyone like to pop a question in the chat box?
Okay, maybe we can keep them for later. So the next question is, how would you manage this patient now? So you've done your ABCDs, he's quite stable. Now he's not in research, he's just in sort of the trolley bay. And what is your next step?
Okay, let's see if you guys have any ideas. So someone said do lab tests. Do you have any specific lab tests that you'd like to do? We have bloods and urine culture, bladder washout with a 3-way cath.
Good. So I'll start answering that. So labs, you said, yeah, absolutely. If someone can tell us what labs, and then I'll go on to the next bit. So you've asked for a urine sample, and he did provide one before that was infected. It looks really dark, and he really struggled to pee. He didn't have a temperature, so they didn't do blood cultures, which was, I think, reasonable.
So in terms of bloods, we have Usinese, LFTs, coag, bone, CRP, FBCs, and someone mentioned a bladder scan.
Yeah, you could do a bladder scan, absolutely. Sometimes if they've got large clots sat in the bladder and you do a bladder scan, it may not depict the actual picture. So if someone is very visibly in clot retention, I don't always get a bladder scan, but yeah, I think that's reasonable. Yeah, all the bloods correct, but I think the most important one is the FBC. You want to check their baseline hemoglobin at this stage. And just to recollect, he has been transfused 2 units, so you likely came in with a low HB and then required 2 units of transfusion already. So yeah, FBC would be important, coag, renal function, and CRP because he has an infection. You could do LFTs in a bone profile at this stage. May or may not be very helpful right now. Because you're not suspecting prostate cancer or something as wonderful and weird at the moment. So yeah, a basic blood test. Oops. So you've done the basic bloods, and then you've checked the urine. It's bloody. The patient's struggling to pee. So what would you do next? Someone mentioned this already, that you would put a 3-way cath and then do a washout. Anything else?
Sorry, I'm just going to interrupt. Someone had a question. What about fibrinogen function?
Yeah, I mean, you mean just a clotting profile? I mean, if they're not on anticoagulants, you could, I mean, if they are on anticoagulants, I usually check the INR. So something very specific, such as a fibrinogen profile, in this sort of emergency situation is probably not relevant right now, but I completely accept that's something that you want to explore at a later stage if they continue to bleed and you want to involve hematology, and if there's anything wrong with their clotting factors, etc., you can correct that. But when you're called down to assess a patient who is likely, the diagnosis is clot retention secondary to something that we haven't really investigated yet. The first step is to relieve the clot retention. So it's relevant, but not at this point.
Okay. So I think your next question was, what would you guys do next after the above investigations that we mentioned?
So did someone already say 3-way catheter, didn't they?
Yeah.
Yeah. So I think I'm just gonna show this then. So yeah, a 3-way catheter and a bladder washout was done as you suggested, and we just got lots and lots of clots out, and started the patient on continuous bladder irrigation. So fairly straightforward here. And then we already mentioned you start the patient on antibiotics because they've got an infection and they have received 2 units of blood. And then so the next thing that happens is that you've checked his bloods again, and his HB is 90. His usual baseline is 120, and this is despite the 2 units of transfusion. So he's probably been bleeding for a while, and his renal function is completely normal. He continues to bleed despite your wonderful washout and irrigation, and the HB keeps dropping. And this is like 2 days later after his admission. You're not able to get on top of the hematuria just by doing the washouts and the irrigation on the ward. What would you do next?
Okay, so what would your next steps be, guys?
So let's recap. So he's 80, he's come in with hematuria, severe hematuria causing clot retention, requiring blood transfusion, antibiotics. You've put in a 3-way, you've done a washout, you've irrigated him for 2 days on the ward. He's still bleeding and his HB continues to drop. So what would you do now?
So we have one answer said blood transfusion since the hemoglobin is low, and Dean has replied surgical intervention.
Sorry?
So we have blood transfusion, and then another answer was surgical intervention.
Yeah, very good. So what surgical intervention would you do? I briefly mentioned this earlier.
So someone said TURP.
Okay. Anything else? Or surgical intervention is one thing. Anything else that you think you want before you take the patient to theatre?
Someone says cystoscopy.
Yeah, so the surgical intervention would be a cystoscopy. And we can discuss that in a minute. Is there something else you want before you take this patient to theatre?
Imaging, so someone said CT.
Very good. So this is a CT scan. Can someone tell me what kind of CT this is? I know, appreciate it's not an easy question, but you all are brilliant, so I think someone's going to come up with the answer.
Okay, so while I give a chance for people to answer which type of CT is, someone else replied CBI. I don't know what that.
Continuous bladder irrigation, yeah, but you've been doing that for 2 days and it hasn't really responded. So you kind of need to change tactic or they'll continue to drop their HB. But yeah, absolutely, that's what you would do on the ward for sure.
Great. So we have someone said contrast CT and another one said urogram.
Excellent. So yeah, this is a urogram, and the reason is because you've got contrast in the genitourinary tract. So starting from the kidney down to the ureters and into the bladder, you can see the white bits, which is the contrast. Coronal and axial films. So obviously, my next question is going to be, what can someone tell me what you can see on the CT scan?
Right, so what can you guys see on the CT? Someone mentioned clot.
Good. So basically, this sort of swirl sign is where the contrast is sort of accumulating around the clots. So yeah, those are clots. This is the catheter balloon, and just here you can see this sort of big mass, which could be anything really. The other thing you want to look for is there any hydronephrosis? Are the kidneys obstructed? But I already mentioned that his kidney function was normal, so it's unlikely, but it's something that you want to check. So his kidneys are not obstructed. He doesn't have any hydronephrosis, but he does have clots, like you quite rightly said. And there is a sort of a mass in the posterior wall of the bladder. Yeah, everybody appreciate that. And yeah, his bladder wall is thickened, and that's not something unusual that you see in people who have an outflow obstruction to their bladder. So when someone's bladder isn't draining that well and they have to do a lot of work to empty their bladder, over time the bladder wall gets quite thick, and that's some sort of an imaging finding that can be reported in a lot of these scans. So yeah, there's a large enhancing mass on the posterior aspect of the bladder. Any thoughts on what should we be doing next, or what this could be?
Just see if anyone has an idea as to what we could do next.
So I'll go with the previous thing when someone said a cystoscopy. Mm-hmm. But what kind of cystoscopy are you going to do? Any thoughts? Does someone know the types of cystoscopies that are available? There's two main types.
So someone said flexible.
Yeah, very good. So flexible is what you see in outpatients. If you go to a clinic and you start watching a cystoscopy list, that's what you'd see. It's usually a 16 French, it's a diameter for a standard catheter, long kind of scope that's flexible. So the clue is in the name. And then that's one type. What's the other type?
So Dean said rigid and flexi.
Yeah, so rigid and flexi. So problem with the flexible scope is because it's a small diameter relatively. There's only one channel for you to pass small instruments through. Usually with this kind of a clot and a mass, you're not going to be able to see anything or do anything. So what he needs is a rigid cystoscopy. Under an anesthetic, it's done on the emergency list. So rigid cystoscope diameter is about, on an average, 22 French, but it varies very widely. And essentially what you'd do is you'd go into the bladder and you would take a look inside, and the first thing you'd see is massive clots in the bladder. So what you'd start doing is using better instruments like an ELIC to evacuate the clots. And then possibly, if necessary, depending on what you see, because you don't really know what this mass is, but you're assuming this could be a bladder tumor. So you possibly get ready to resect this tumor if there is one. So you get the theatre team to get all of that ready. But yeah, the thing to take away from this is you book them on the emergency list for a cystoscopy and a clot evacuation, plus minus whatever you find inside, and you try and deal with that at that stage if it's actively bleeding. So for this chap then, they went in, they evacuated 400 cc of clot, but they didn't see a bladder tumor. But instead, like everybody predicted, he had a very large prostate, a very large intravesical median lobe, so basically they got all the clot out, and at that stage they just diathermized the bleeding points, and then later on he elected to have a TURP for the management of his BPH and hematuria. So BPH can cause significant hematuria. It's up to 12%. Gross hematuria requiring transfusion with BPH can occur in up to 2% of patients. And this is because of neovascularity of the prostate adenoma. So it brings with it a lot of new blood supply. And that's where you can also treat this. If it's not, the bleeding isn't this bad, or even otherwise, you can start them on finasteride, which is a 5-alpha reductase inhibitor. And it is known to sort of shrink the prostate over time, but can also help with reducing this neovascularization and reducing the risk of hematuria. Or you can offer them bladder outflow obstruction surgery. Could be a TURP, could be a HOLEP, etc., depending on what your center has and how big the prostate is. That's really it. So essentially the take-home points for everyone when you see such a patient, identifying clot retention is really important. The patient will be clinically in retention, pain, passing urine, not being able to empty their bladder, palpable bladder, passing blood, frank blood, which sometimes you might be able to see clots, etc. So stabilize the patient, and then the first thing you want to do is, after you've stabilized a patient, is put in a 3-way catheter. Do a good washout. Cannot stress how important a good washout is, because if you haven't done a good washout, you've left clots behind, the patient's going to keep bleeding, the catheter is going to keep blocking, you'll keep bypassing. So good washout is absolutely key. It's important to start off, maybe watch someone from urology do it, and then start practicing this if you see many of these patients. Then you make sure they're on irrigation, the irrigation doesn't run out, they don't clot off on the ward in the middle of the night sort of situation. And then majority of them, as I said, will recover and go home at this point in a couple of days. If they don't, think of what to do next. Don't wait around for a long period of time. So ask questions. Can we image them? Should we take them to theatre? And at all times, good medical management. So check their hemoglobin every day, clotting profile, antibiotics if they've got an infection. That's really it. If you are sending these patients home and you haven't taken a look in their bladder, do not forget to book them for follow-up for the cystoscopy and upper tract imaging when you discharge them. Sometimes people may forget to tell you to do that if you're an F1, but that's something that you should really make sure that it's done for that patient when they go home. Yeah, that's everything I think that you would need to know at this level for hematuria, as in clot retention. Any questions? I think that's my next slide.
Right, so does anyone have any questions they'd like to put in the chat box? I have a question here. Are there any contraindications to a 3-way catheter?
I mean, I would always try, but yeah, if the patient has had a known urethral stricture, for example, or they have multiple false passages from a previous difficult catheter insertion, and you're not really happy to do it, you can call the urologist with that. But majority of the times, if you can put in a standard catheter, a 3-way catheter should go in. If there's a stricture and they are in clot retention, call the urologist.
Right, okay. Let's have a look. Any other questions, guys? So here's another one. If they are on anticoagulation, what would you do, say in the setting of atrial fibrillation?
Yeah, you just have to hold it. AF is fine. Majority of the times, if you hold it for a couple of days, they're usually all right. You can put them on prophylactic dolutegravir and TEDs, and usually it's not a problem. Now, if someone has a metallic heart valve or something like that, that's a bigger problem, and you have to involve cardiology and hematology. A lot of these patients need to be on their anticoagulant, so it's sort of a risk benefit discussion you have with the medics and the patient. If they're bleeding really, really badly, sometimes you have to hold them for a day or so. A lot of the times, if they're high risk, we try and continue them if we can. And for example, if someone has a recent MI and they're on dual antiplatelet treatment, that's a really tricky situation to manage, and it happens sometimes. So you try and start doing their bladder care without stopping their antiplatelets initially. But then if it's not responding to your washouts and irrigation, it might be that you might have to stop their antiplatelets after discussing with cardiology.
Okay, so Maria has asked, can you put a catheter for a patient with hypospadias?
Yeah, it depends what kind of hypospadias it is. So hypospadias is a range. So it could be distal hypospadias going down to proximal. So I'm hoping you never have to see a adult with a proximal hypospadias. But yeah, if it's a distal hypospadias, essentially, for those of you who don't know, hypospadias is where the urethral opening is on the undersurface or the ventral part of the penis. So it's sort of inside on the undersurface rather than on the tip. So if it's a glandular or a coronal urethral opening, then absolutely fine. But you need to know where the urethral opening is. So if you can't find that and you keep sort of trying to go where they sometimes will have like a depression at the tip of the glands where they should have the urethral opening, but it's not there. So you have to kind of look underneath, and that's where you would see it. But yeah, it's not a contraindication. You just need to know your way around that. But if you don't feel comfortable, yeah, call the urologist.
Sorry, I just realized I was on mute there. So someone asked, is there any contraindications to doing a washout?
Not really. So if someone's on clot retention, yeah, I don't think anything would stop me from doing a washout unless you're not comfortable doing it. That's really the only thing. I mean, a lot of people get really scared with a 3-way catheter and a washout because first of all, the catheter looks massive, and then you feel like you're sucking stuff out of someone's bladder, and the patient will always be in agony. But if you can put in a 2-way catheter, the technique for insertion of a 3-way catheter is exactly the same. For a washout, I mean, as long as you do what I said what the video said, really, where you actually fill up the bladder a little bit and then start sucking on the clots, is absolutely safe to do.
Okay, and the final question was from Dean. Is the management the same for patients with a suprapubic catheter?
Good question. So suprapubic catheter, you can't obviously put in a 3-way from the suprapubic tract. I'm sure you can, but the tract is of a certain size, and that's not what you would usually do. So if someone with suprapubic catheter has come in with hematuria and they're bypassing, because that's how they'd present. So if you can access the bladder urethral, I'd put in a 3-way urethral. If you can't, if the urethra has been closed off or they've got a stricture, or for whatever reason you can't get into the urethra, then I would put in the biggest 2-way you have in the suprapubic tract, and then wash out the clots and see what happens. I mean, if it gets that bad that you are starting to think whether they need the 3-way through the suprapubic and there's no access to the urethra, call the urology reg, because we'll figure it out usually. But yeah, so these are the things you can do. Put in a 3-way through the urethra if accessible. If not, put in a bigger suprapubic and wash out the clots using a 2-way.
Okay, great. I don't think we have any more questions at this point, but I'd actually like to ask a question myself before we finish. So do you use tranexamic acid at all in these patients? I've seen that quite common.
Yeah, very controversial. So, so just as a background, obviously tranexamic acid helps in clotting. A lot of trauma surgery and other bits of bleeding, like gynae example for menorrhagia, commonly use that. Now, the biggest problem with urology and using tranexamic acid traditionally is the fact that it can form clots, and the clots that form after you've given someone tranexamic acid quite dense. They're very hard to wash out and break up. So a lot of people are quite hesitant. So it depends on the center I've worked in. Some centers are very sort of lax about giving it. And in someone who has refractory hematuria, that you've done everything possible and it's just not stopping, I think you can give tranexamic acid. And I've done it in some hospitals and it's been absolutely fine. It really depends on the center you work in and their policy, because their data on this is really sparse and the evidence is really weak. So to be honest, it depends on your boss is how I would say it. If I were the boss, then I'd probably, if they have refractory bleeding, they're elderly, I've done everything possible, yeah, I would then try tranexamic acid. 1 gram BD is what I've given before. Some people also give it stat, so they give like a 1 gram IV, and sometimes that works. Like I've seen it been given post-op after a TURP or a HOLEP if they're bleeding, just a stat dose.
Right, okay, thank you very much. I don't think anyone else has any questions, so I think we'll conclude. Thank you very much for everyone who's joined today, and thank you, Nikita. It was a really, really good session, in my opinion. So I've just popped the feedback link in the chat box, and there's a QR code here for those who prefer to use a QR code, but we'd really appreciate your feedback. You guys can get certificates from that as well, but most importantly, we want to try and give you the sessions that you want to be delivered. So feel free to go ahead and do that. And otherwise, if you have any other questions later on, just send us an email to the urology email, and I'll be happy to forward that on to Nikita, and we'll get you a reply. Otherwise, you can go to the mindthebleed.com website and find all our recordings as well as our reading material. And make sure you join us next time for scrotal emergencies. So thank you very much.
Thank you. Thanks for having me.
Thank you.